Bilateral posterior retroperitoneoscopic adrenalectomy. Posterior retroperitoneoscopic adrenalectomy was developed as an alternative minimal invasive approach and provides fast and direct access to the gland. This is a case of a bilateral adrenal tumors measuring 5 by 4.3 cm on the right and 1.7 by 2.2 cm on the left in a MEN 2A patient with a history of medullary thyroid carcinoma. Endocrine workup is consistent with pheochromocytoma. Patient was placed in prone position, semi-flexed. Trocars were placed below the 12 rib, middle, and approximately 5 cm medially and laterally. Partial adrenalectomy left. Upon access of the retroperitoneum, blunt dissections of the landmarks were done, followed by the identification and dissection of the upper pole of the kidney. The adrenal gland was then mobilized freely. It is critically important to dissect the adrenal of the kidney. This was then followed by the dissection of the medial border of the adrenal mass. The adrenal mass was then identified and dissected from the normal adrenal gland using ligating clips. Mobilization of the adrenal mass was completed using vessel sealing device. It is important to avoid grasping the actual parenchyma because it is easily fractured. Hemostasis of the adrenal bed was done, followed by placement of absorbable hemostatic agents. The adrenal mass was then placed in a specimen bag. Total adrenalectomy right. The retroperitoneal space is developed using blunt dissection, which is followed by the identification of the anatomical landmark, which is the upper pole of the right kidney. Followed by the dissection of the lateral border and medial border. Once the adrenal vessels are identified, these are ligated using vessel sealing device and ligating clips. Gentle manipulation of the adrenal mass while avoiding grasping the adrenal tissue and parenchyma was done during the dissection. Occasional blood pressure elevation was encountered and adequately managed. The large adrenal mass was meticulously lifted off in order to fully expose the vena cava and adrenal vein. It is followed by ligation of the right adrenal vein using ligating clips. Total of 3 clips on the patient's side was left. The remaining attachments were dissected. Once the adrenal mass is fully mobilized, it is then transferred to a specimen bag. Manual retrieval of the specimen was done, as well as withdrawal of the trocars. Total operative time was 3 hours and 31 minutes with minimal blood loss and stable vital signs. Post-operative condition. Patient was able to ambulate the next day with minimal pain and was subsequently discharged on the second post-operative day. Upon follow-up, the patient's hypertension was controlled without the need for medications. There was no need for steroid supplementation. Histopathology showed adrenal mass consistent with pheochromocytoma.